Hi there. I'm so glad you could make it to our program today, which is all focused on endometrial cancer, especially the recurrent and advanced stages, and really focused on shared treatment decision making. In other words, how can you play more of a role in making these decisions and also in considering clinical trials? Are they right for me? So, first, as an introduction, my name is Stephanie Trong. I am a former cancer patient, a patient advocate. I am also the founder of The Patient Story. And I want to just say that through my own diagnosis, although it was different, it was a blood cancer, there's so much medical jargon out there. And really, our goal here is what I wish I had had, which is to sort of cut through that noise. And so that's what we aim to do here at The Patient Story, is to humanize information after a diagnosis through educational conversations like today's and through our incredible in-depth patient stories and videos. We've got hundreds of those with incredible people. Feel free to take a look. That's at thepatientstory.com. So again, today, our goal is that you walk away more empowered in your own care, whether it's your own care or your loved one's care, and where you're in a better position to ask the healthcare team about the best treatment options for you or your loved one. Before we begin, a couple of things. First, we want to thank our sponsor, Karyopharm, for its support of our program, which allows us to bring you education from the experts at no cost to you. And that's what we're striving for, is to be able to do more of this. The Patient Story retains full editorial control of our content. And while we hope that this is helpful, please keep in mind that this is not meant to be a substitute for medical advice. So consult with your own healthcare team about your decisions. And lastly, we always want to hear from you. We know that it takes a lot to set aside time, that there's a lot going on in your lives. We want to make sure that this is worth your while and that it's truly helping you. So a survey will pop up at the end of this discussion. Please let us know what we could do better, what you want more of, what kind of content, from whom, what topics, and that will come again after this program ends. So today I am so pleased to be joined by someone who has been a friend of the program before, Dr. Brian Slomovitz, who has many different things that I could say in terms of all the bullet points about your experience and what you do in the space. But I'll just name a few: Director of Gynecologic Oncology and co-chair of the Cancer Research Committee at Mount Sinai Medical Center in Miami Beach, Florida. Also holds a professorship in obstetrics and gynecology at Florida International University. And with GOG Partners is the uterine cancer clinical trial lead. On that note, Dr. Slomovitz's clinical expertise spans so many spaces. We're talking immunotherapy, clinical trial protocols, where he's led critical studies in ovarian and endometrial cancer. And also Dr. Slomovitz involved with so many patient advocacy groups and efforts. And so first, I want to say thank you for making the time to join us again today. We know how busy you are, and you have so many of your own patients. So what drives you to do things like this, where you're helping not just your own patients in clinic, but the many out there who are looking for more information? What are your drivers?
Yeah, well, first of all, thank you very much for having me. I really appreciate it and the opportunity, Stephanie, to chat with you and to the Patient Story audience that's out there. I think when we talk about what we're doing as gynecologic oncologists, our responsibilities are not only to clinical care, they're also to research, and we'll be able to talk about that more. They're also about educating our trainees, our residents, our fellows, our medical students. But I think equally as importantly, I always say the best way to cure cancer is to prevent cancer. Endometrial cancer in specific has some risk factors. I think it's important to educate the community of the non-diagnosed patients, that's sort of called pre-vivorship, and then diagnosed patients to make sure that they ask the right questions amongst their doctors to make sure that they get the best care moving forward. Ultimately, that's what's going to help save lives. And I'm passionate about this. You know, we went into medicine to do what's best for our patients. And fortunately, I've been given the opportunity to work in this setting and in this arena to try our best to eradicate this disease.
And I so appreciate that. And I know our patient community does as well. Then, since you mentioned it, can we just spend a brief moment talking about the signs and symptoms of endometrial cancer? I know this is, we've talked to so many people who've had, unfortunately, a long path to getting the diagnosis. So maybe helpful to understand some things to watch out for, some of the questions that people can ask their doctors when they start to feel not well.
So no, that's a great question. I think Fortunately, most women with endometrial cancer are diagnosed with early stage disease. Obviously, there's a large subgroup that have advanced or recurrent disease that we're working on with better um, systemic therapies, clinical trial options. But the reason why we have mostly diagnosed with stage 1 disease is postmenopausal bleeding or abnormal bleeding. If there's any signs of abnormal bleeding, we're really need to educate our patients to go see their healthcare providers. Oftentimes, it could be nothing. It could be a polyp. It could be in a premenopausal woman, an abnormal period. But there's also cancers and precancers which need to be diagnosed, and that could be done by a simple office procedure. So it's important.
Thank you for covering that. And so for those who are newer to understanding this diagnosis, let's talk about the different kinds of people you're seeing. By the time they see you, they've been referred to a specialist, right? What are the first sort of questions you ask the people you see to help understand how to make the best treatment recommendations?
Yeah, so endometrial cancer is becoming more and more a heterogeneous disease, and we're getting better at dividing these patients into subgroups. Now, the when a patient comes into my office with a diagnosis of endometrial cancer, the first thing I think of in my mind is, why did that patient get endometrial cancer? Now, there's a large subgroup of patients that have the typical standard endometrial cancer, something called endometrial cancer. This is really driven by obesity. Okay, obese cells, fat cells in the body produce estrogen. So the heavier a person is, the more likely they have higher estrogen levels. And it's the estrogen that sort of feeds the lining of the uterus, the endometrium, which could transform it into a cancer or precancer. So when we talk about, we talked about the opportunities for prevention. Weight loss is a tremendous opportunity. And we're in 2025. Ozempic, Mounjaro, the GLP receptor antagonist. I'm a big advocate. I am. I think whatever, especially women who tried other techniques to lose weight. And if it doesn't work, by decreasing one's weight, you could decrease the risk factors for endometrial cancer. Now, we're still doing the definitive studies, but I can't imagine that they're going to be negative. Other risk factors, we always have to look at family history. There's a hereditary predisposition to endometrial cancers in something called Lynch syndrome. It's a hereditary syndrome that could lead either to endometrial cancers or even colon cancers, and a small group can get ovarian cancers as well. So in strong family histories, we're looking for that. History of PCOS or polycystic ovarian syndrome can lead to endometrial cancer. And then there's always the sporadic, I just say the bad luck that can lead to it. But we really want to try to figure out why they showed up in the office, what brought them there, what risk factors.
That's so important. And how important, I guess, is it to be able to see someone like you in a space? Because we're going to be talking all about today the different research, the latest in terms of treatment options, especially for advanced recurrent endometrial cancer patients, where we know that there were limited options in the past. So I guess starting with that, how important is it to see someone like you who also does so much research outside of seeing patients in the clinic?
Yeah, no, I think that's thanks for that question. I think that we want to make sure our patients see a subspecialist in gynecologic oncology. Now, to get to where we are today, I did 4 years of residency in OBGYN, and we do 3 to 4 years of fellowship. I did a 4-year fellowship at MD Anderson. That's after med school. So we're really passionate about what we do. I think that, to seeing a clinician who does a lot of this is important. But as mentioned, I'm really passionate about research. We're not going to rest until we get 100% cure rates, right? And I think it's important to talk to your doctor about what clinical trial options are there, what clinical research is going on. It's important always to get the right opinion, the correct opinion. It means it's okay to get second or even sometimes third opinions. And it doesn't always have to be your own doctor that does it, but at least in partnership or one who collaborates with a researcher in the community to really make sure that we get the best treatment options for our patients. And the best outcomes come to those patients that have the opportunity to do research.
100%. Yeah, and I love that you mentioned that. Yeah, I love that you mentioned the working also with maybe community providers, because I don't think we hear a lot about that, but it's having a full team, maybe someone like you who does a lot of the research, partnering with, a lot of people might not live close to where you practice. And so is there a way that they can still access being, under your care? And it sounds like that happens.
Yeah, no, I'm fortunate. I'm in Miami. I'm fortunate I get several patients from South America, Central America, even Europe, because a lot of these trials are only available in the United States. And patients, for good or for bad, patients with resources oftentimes come to seek out some of these trials.
Yeah, absolutely. And so we'll talk a lot about clinical trials. Before we get there, Dr. Slomovitz, we've been hearing a lot on the whole about more personalized medicine and understanding not from a population, but for me as an individual, some information that can help you better, make suggestions on treatment. So one of those, we talk about biomarkers. What are the key biomarkers? If you could describe what that is in layman's terms, first of all, and why they matter in especially advanced and recurrent endometrial cancer.
Sure. So let's take a moment to talk about this. Back in 2011, 2012, there was something called the TCGA, or the Cancer Genome Atlas, was created to do full genetic sequencing of tumors. Now, of all of the solid cancers that were investigated, endometrial cancer was the one that really was able to delineate the disease into four distinct subgroups. Something called microsatellite instability or deficient in MMR proteins. I know this is technical. Something called POLE mutations. Those two groups that I said are really respond well to immunotherapy. And we'll talk about that. The other two groups are something called no specific molecular profile, or P53 abnormal. Those are the ones that don't just respond to some treatments, need other things. So in general, those are the four subclassifications that we look for in endometrial cancer. Now, we're also looking for, in addition to this, what I mentioned, the mismatch repair proteins, we look at estrogen receptor status, progesterone receptor status. A protein on the cell called HER2 is important when we come up with treatment options, and also P53 mutation status. Again, these are biomarkers that we use. They're sort of signatures that, again, change the diagnosis from endometrial cancer to a P53 mutated estrogen receptor negative and a microsatellite stable tumor, if that follows. Now, using those classifications, then it comes into better treatment options, because we define our treatments by the different molecular subclassifications, which is totally different than what we used to. Not all treatments are the same for different patients.
100%. No. And you mentioned, thankfully, that a lot of the initial diagnosis in endometrial is stage 1. We also know, though, that there's recurrent. So can you break down approximately how many people have the recurrent diagnosis, and then also how many are diagnosed at an advanced stage from the beginning?
Yeah, so it's a great question. First of all, to lead into that answer, there's more women now who die from endometrial cancer than from ovarian cancer. Now, we used to think of ovarian cancer as the silent killer. We're not sure exactly why. There's an increase in incidence. We're doing a better job in identifying some endometrial cancers, particularly across diverse populations. But it's a deadly disease. I think, the standard of care at first is a hysterectomy. After hysterectomy, we find about 70, 75 patients, maybe 80% are diagnosed with stage 1 disease. It's those other patients that we're more worried about, the patients with lymph node involvement, or spread to the cervix, or spread to other parts of the abdomen. Those are the advanced stage patients, and they require systemic therapies. Of those patients, the recurrence rates could be quite high. Patients with advanced recurrent disease, recurrence rates could be 60, 70%. So again, leading it to the fact that it's the deadliest of all gynecologic cancers. Even though 70% could be treated with surgery alone, it's that other 30%, and they could be advanced stage. Also high risk, some of the high risk histologies, that P53 abnormal group, are the ones that are set up for recurrent disease as well, that we need to come up with more systemic treatment options.
Is there anything else? I mean, that was really well laid out. Is there anything else that you want patients to know by the time they see you and they have either advanced or recurrent endometrial cancer? What are the top things you want them to understand about the landscape of treatment options and what's available?
Yeah, no, that's great. I think it's important that we make sure we offer the best standard of care for our patients, that we take the time to explain that to our patients, what the best treatments are, and then what clinical trial options there are available. And it's really important. A lot of times patients and their families say, well, let's get started on treatment and then find options. I would say I'd rather wait a couple of weeks to start on the right treatment option, on a treatment option, to make sure it's the correct treatment option. Because oftentimes when you start, you can't really go back and you go back to say, oh, forget it, we shouldn't get the chemo, we need to give this clinical trial. So it's really where you start your therapy, and the options at that point are crucially important, because it may eliminate your eligibility for a clinical trial.
Right. And again, we're going to spend a lot of time talking about that. So let's start then with what has been the gold standard in terms of standard of care for advanced and recurrent endometrial cancer patients.
Yeah, so this recently changed. Initially, it was just chemotherapy, sometimes with or without radiotherapy. Now, in March of 2023, two presentations were presented at the same time at the Society of Gynecologic Oncology meeting. The studies were very similar. They added immunotherapy to chemotherapy in this first-line management of this disease. Both studies were positive. Okay, and there was actually two other studies that were also positive. So the designs were similar. It was chemotherapy plus minus a drug called pembrolizumab, plus minus a drug called dostarlimab. There was another drug, atezolizumab, which investigated, and durvalumab. All of those studies showed the same thing, that immunotherapy works in women with endometrial cancer. So from that day forward, it's at least a clinical trial option. I'm sorry, a standard of care option for our patients, particularly, as I mentioned earlier, in that subgroup of patients with microsatellite instability, or DMMR, or in layman's terms, a certain molecular profile. If patients didn't get immunotherapy in the first line, immunotherapy studies have shown also works well in the second line. So when we talk about first line management, I think that's the standard of care. But there's also some other clinical trials that we're looking at treatments that may actually be better. There's also a subset of patients that may be eligible for less than chemotherapy, hormonal therapy for this disease. That's sort of a smaller subgroup, but in general, I would say the best treatment options are chemo with immunotherapy.
And just to follow up on that, who makes up that small population that benefits off the less than chemo hormonal therapy?
Yeah, it's a subgroup of patients that have less aggressive disease. Maybe they have metastatic disease, but it's just one area that's maybe has an indolent or slow growing growth pattern, estrogen receptor positive. It doesn't mean we'll eliminate chemo, but we may start those patients off with non-chemotherapeutic options. We're also studying in some patient populations immunotherapy in the first line without chemotherapy. Okay, and some of those studies haven't even read out yet, but there's one study that I'm leading globally with the drug pembrolizumab. Again, in this DMMR patient population with advanced recurrent disease, giving immunotherapy alone versus chemotherapy alone to see if that's actually better.
It's exciting that there's so many things that are happening in the space. Historically, what have been the issues with all the chemo? I know a lot of this is about quality of life. And so, what would you have to talk to patients about in terms of helping with that?
Yeah, so, I would just like to say one of my career goals is to get rid of chemotherapy for this disease. Why? The response rates to chemotherapy, even in the first line, are about 50-52%. The duration of response, or the progression-free survival, is only about 14%. Those numbers aren't good enough. So if we're able to improve efficacy, and to your point, there's side effects of chemotherapy. So improve efficacy while either maintaining or improving the quality of life is our ultimate goal. And we can see that, hopefully, with immunotherapy. If the studies are positive about getting rid of chemo, that'll be super exciting. And if the studies on the hormonal therapy and biomarker-driven therapies that are ongoing, that would also be exciting to hopefully get rid of chemotherapy.
Is there anything else in terms of for the standard of care right now? And I guess actually drilling down on that, because we know you're at this large center, you're a specialist. Are you hearing from patients though who've been in the community who are still getting only chemotherapy, or what are the things that we can be doing as a patient group to help even make sure that the right treatment option conversations are happening?
That's where some of the frustration starts. So right now at my center in endometrial cancer, I have one study in the adjuvant setting before it even spreads. I have two studies in the first line setting, to give the best treatment in the first line. And I have several studies, maybe 7 or 8, in the second or third line. setting for this disease. It's okay to get good standard of care. I don't think clinical trials are for all patients, but I think there are some patients that are super motivated that want to improve their treatment options. What we're using in the first line is we're using some of the second line therapies that we've been proving to work and moving them to the first line to see if they work better in the first line. We know a lot of times that we've seen that. Chemotherapy works better the first time you give it. Hormonal therapy works better the first time you give it. So in some of these novel therapeutics, by pushing them to the first line, it may be more beneficial to our patients, but we don't always get referred those patients, which would be nice if we did.
So part of this is just trying to get the attention of people that these options exist and that there are particular places you'll need to go, most likely, to get access to them, right, to these clinical trials.
And Stephanie, that goes back to the first question of the interview. Why do I do what I do? Why do we do this? Because we have to get the word out, right? So we're hoping that your audience may have a family member that says, oh, wait a second. I live in New York, so I need to go to a major medical center in New York. I live in Florida. I need to go to a center here. Through my group that I work with, the GOG, which is Legacy, something called Gynecologic Oncology Group, we're a national organization. Actually, we have international partners as well. Over 350 sites. So our goal is not to get the best clinical trials, but to get the best clinical trials nationwide. That patients don't need to travel so far for their care. They don't need to go to, some of the best cancer centers in the world. They can get it locally and closer to home.
I love that. I love that there's an effort to get access out there to more people. Before we dive into the clinical trials and also describing, I hate the phrase itself because I think it could be intimidating for people. But what are the questions? I know you've talked about biomarkers, you've talked about different groups, that certain groups do better. Maybe it's shown in studies with immunotherapy. Some other groups need to have other options. But what are the questions that people who have no idea about the diagnosis, what can they be asking their local doctor about themselves? Testing that needs to happen. When does the testing need to happen?
Yeah, I think it's important. I think, biomarkers in general could be prognostic, meaning they could tell how well the person's going to do, or they could be predictive of a certain response. We also have specific biomarker therapies as well. In talking to their doctor, they need to be somewhat educated. Doctor, what's the best therapy out there? What are the best therapies that are being investigated? Are there any treatments just for my biomarker signature tumor? Are there others, that work in general? So I think sort of having that lingo down makes a lot of sense. If they go to their doctor and the doctor says, well, we really don't have clinical trials in this area. That's, my work would be considered not successful then. We have clinical trials available. We have a lot of clinical trial options available for our patients that we want to talk about. So they should talk to their providers about it and make sure, to the best of our ability, have the patients at least see a provider who offers clinical trials, even sometimes by telemedicine. If they're calling from a distance, in the state of Florida, we can do telemedicine visits, and that could help educate patients on options and also educate us to whether or not a patient is eligible for one of these trials.
So it sounds like, I know you mentioned you work with patients from everywhere, Europe, Central, South America. So you're saying telemedicine is still available where you are to be able to give consults or to be able to provide some medical guidance to people in other states?
Yeah, there's certain billing rules there. So there's certain, as far as the ones we formally can see within the state of Florida. But even so, if the patients are calling internationally, we try to give us an opinion to see whether or not there's actually options for the patients. So, but yeah, we want to, and if they don't, maybe sometimes, for example, the trial may not be open here, it'll be open in another area of the country that they'll be able to get those options.
Okay.
I'll give you an example. For a cervical cancer trial that I had, okay, I had patients coming up to see me from Argentina because not only could they not get the trial in Argentina, not only is it not available, the drug in Argentina, well, the trial wasn't available. So being in the United States, oftentimes we have access to some agents and trials that aren't available globally.
I'm so glad again to hear about that access. So let's dive right in. How do you describe clinical trials as an option to your patients, especially those, of course, Advanced stage, they're probably, feeling pretty overwhelmed. Recurrent, they've already gone through treatment and they're like, I have to go through something again. How are you having that conversation with them and describing it?
Yeah, I think the first thing is as far as what they could possibly get is understanding their medical history, what they've already gotten and where they stand. As I mentioned, over the last couple of years, we've learned that immunotherapy is a good option for our patients. A lot of the trials that we're writing now require prior immunotherapy because we don't want to test something until they get the best care so far. And then as we move forward into what trials are available, clinical trials are almost like a cookbook that you need to follow, right? They're looking for a drug registration. They're looking to be compliant with the FDA guidelines. So there's specific screening or eligibility criteria and exclusion criteria that we go through with our patients to see if in fact they're eligible. Some of those could be how many lines of therapy, what biomarkers are present on the tumor, other medical comorbidities or problems may limit them from being in the trial. So it's really getting to know our patients and then seeing what options there are. There's a new class of drugs, something called antibody drug conjugates. They're chemotherapies, but they're chemotherapies targeting specific proteins on the cell. That's going to be, I believe, the next line. So we talked about immunotherapy and chemo are being used. The next is going to be what's the best agents to use after chemo and immunotherapy. And I do believe it'll probably be a large component, at least, will be these antibody drug conjugates. And they're under investigation now. And right now we have about 9 to 10 trials just looking at antibody drug conjugates. They have different targets, sometimes different chemotherapy attached to them, but we're really looking to see what the best ones for our patients. Then as we move forward past that, we need to see, right now we're doing post-immunotherapy, post-chemo. At some point, it'll be a day that patients receive an ADC as well. So we're already doing those studies looking to see what the best treatments for those patients are too.
Yeah, sounds like so much is moving. So if we were to break this down, so we can talk specific clinical trials, the ones that you find the most promising or exciting, and maybe break it down also into those distinct groups that you were talking about or subgroups. How would you highlight maybe the top clinical trial for, say, the microsatellite instability high group?
Yeah, no, it's a great question. So the tumors that we talked about are very amenable to immunotherapy. I sort of alluded to this, but what can we do to get rid of chemotherapy? So we're giving those patients immunotherapy alone. Again, this is a trial that's called Keynote C93. We're finished accrual. Hopefully it will read out in the near future. But in those patients with microsatellite instability, giving them chemo alone, chemotherapy versus immunotherapy alone. If that's a positive trial, it'll be a game changer. Now we've seen that already in microsatellite instability colorectal cancers. Okay, a couple of years back, there was a study out of Sloan Kettering, 13 patients, microsatellite instability treated with dostarlimab, 13 for 13, they all responded. More recently this year, presenting, I think at the AACR meeting, there was a study in patients with microsatellite instability. Not only did the treatment work, and there were colon cancer patients and other diseases as well, including endometrial. Not only did the immunotherapy work, but we were able to avoid surgery in a subgroup of patients. Now, forget about getting rid of chemotherapy. Imagine if we get rid of surgery as well. How great that would be for a patient. So that's that subgroup. Okay, one of the areas I think we need to do better now in the microsatellite instability subgroup, we know that immunotherapy works, but there's a subgroup of patients that don't work. What is the role of giving immunotherapy after immunotherapy? And that's an issue that we're investigating now.
Can you talk about that a little more? So you're saying for what the subgroup where immunotherapy first doesn't actually work, if a second line of a different kind of immunotherapy might work?
Well, yeah, we're wondering whether we can give a different immunotherapy, or at the time that it fails, adding another drug to the immunotherapy. For example, there's a drug called lenvatinib. Lenvatinib we know works well with pembrolizumab, the immunotherapy, and lenvatinib is sort of a targeted therapy in patients with proficient MMR, mismatch repair protein, or microsatellite stable. One of the things that we're finding in those patients with the microsatellite instability that respond to immunotherapy alone, if the immunotherapy starts to fail, we're adding lenvatinib to that and we're seeing some responders. So, as another option for our patients.
Is there a clinical trial name for that one, or?
That one's still right now. It's based on anecdotal evidence case series, but we're going to be looking at it more closely.
Got it. Okay. And again, just to so that's Keynote C93. Is that right for the original? Okay.
That's the study that I'm doing with pembrolizumab versus chemo, and there's actually a similar trial that's being run in Europe called Dominica, which is dostarlimab versus chemotherapy for the microsatellite instability or the DMMR patients.
Got it. Okay. That's great. How about, is there anything else in that group that you want to highlight? If not, we can move on to a different subgroup that you want to highlight some clinical trials for.
Yeah, I think that's right now, that's the key message in that population of patients. Now moving on, let's move on to the PMMR, the proficient mismatch repair. I mentioned there's an adjuvant trial that's about to open, but it's in the public domain, in patients with HER2 expressing tumors, early stage, so they just had surgery. We know the standard of care there is chemotherapy. We're going to try chemotherapy compared to an antibody drug conjugate that targets this HER2 protein. If that's positive, we can maybe push antibody drug conjugates into the adjuvant setting, not even the first line. Now, in the first line setting, now we have two trials that are very, very exciting. Both of them are incorporating antibody drug conjugates. One of them is in the treatment arm. It's a 3-arm study. This is sponsored by AstraZeneca, being led by Vicky Macker, a professor at Sloan Kettering. We're investigating the combination of chemotherapy with immunotherapy. Remember that afternoon in March 2023 that I said changed the world. That's the standard of care arm. In the other 2 arms, we're combining immunotherapy plus an antibody drug conjugate. These are also for HER2 expressing cells, to see if either of those 2 arms work. And again, super exciting. If they're positive, it gets rid of systemic chemotherapy in those patients. Another similar trial that we're doing is looking at antibody drug conjugates, but not in the treatment setting, more in what we call the maintenance setting. Okay, so that's after patients respond to chemotherapy and immunotherapy, giving one of these antibody drug conjugates alone or with immunotherapy to help keep it away. Another exciting first-line trial, which is ongoing, which it's another maintenance trial, is looking at in patients who respond to chemotherapy without immunotherapy, giving a drug called Selinexor, which is a nuclear transport inhibitor, to try to keep the disease away longer. So right there, I described an adjuvant study and 3 first-line studies for the management of this disease. How cool is that? I mean, and forget about the DMMR setting, which we talked about 2 other studies that are ongoing. So there's a lot of different treatment options for our patients in the clinical trial world.
That's really incredible. Can we do a deeper dive on what you've just described? Because I think there's a lot to uncover there. So first, these are all in the PMMR group, is that right?
So those trials that I described, whether they're in the PMMR or the DMMR, most of them are PMMR. Some of them may allow DMMR, but we're not going to accrue. The DMMR patients are getting immunotherapy. It works. 70% reduction in recurrence or death due to the disease. So it works. So it's really the PMMR subgroup, the proficient mismatch repair, where we need to come up with better treatment options.
Got it. And what percentage of this cancer patient population or group is in this PMMR group?
About 2/3 are PMMR. Yeah, 2/3 to 70%. So it's a good percentage.
So let's break down again. You're talking about, I know, like HER2. People don't typically, they think about breast cancer a lot when they think about HER2. Just as the campaigns that are happening out there. What would you like to say about patients who have HER2 expressing tumors? Is there a particular patient profile? Are there other questions that they can ask? I know we talked about biomarkers, but we didn't really go into the testing that is required and when that can happen. So
yeah, I'm glad you brought that up, because what I failed to say in the one study that replaces two of the arms are antibody drug conjugate, just looking for the HER2, happens 20 to 30% of patients. usually portends a worse prognosis. These are the ones with a higher, more aggressive histology. Okay. Interestingly, we're finding this also affects more likely women of diverse backgrounds. Black women have twice likely chance of dying from endometrial cancer than white women. And these HER2 expressing tumors we oftentimes see in Black patients as well. Now, the other study, the maintenance trial that I discussed with the antibody drug conjugate, this is with a drug we call SAC-TMT. It allows for all comers, not biomarker driven directed. So regardless of it's an antibody drug conjugate against TROP2. That's found on most cancers, not, but the study doesn't have to pre-qualify itself by having overexpression. When we talk about what makes it positive, it's immunohistochemistry. It's basically putting a dye on the tumor cells that's attracted to a protein that would be on the surface. And the dye needs to be overexpressed, either moderately to heavy.
This is the one that's being led out of Memorial Sloan Kettering? Is that the one you're talking about?
No. So the HER2 study, sponsored by AstraZeneca, the study name is DE01. That's a study that's being led out of Vicky Macker from Sloan Kettering, yes. But it's being run through the GOG in partnership with our colleagues in Europe called ENGOT, E-N-G-O-T. The other study, the TROP2, is a Merck-sponsored trial being led by Dr. Brad Monk, who's an investigator at Florida Cancer Specialists. And the third trial I talked about, the Selinexor trial, the nuclear transport inhibitor, that's being led by Rob Coleman out of US Oncology. And then the adjuvant trial I talked to you about is by Kara Matthews at Brown University. So we're really getting a lot of, part of my job is to make sure we get a lot of different investigators involved with these trials. And I'm really proud of the fact that we're really getting, we're training our next generation of gynecologic oncologists. Is what we need to do for our patients, because we want to make sure that this research continues.
Let's talk a little bit more about the, just to sort of give a layman's view of the science behind some of this. You talked about immunotherapy really well. You talked about the ADCs and the space that's popping up there and the excitement there. Then you talked about Selinexor, which is a completely different mechanism. So can you describe some of the science behind that and why that's being studied in the maintenance setting?
Sure. So Selinexor is a nuclear transport inhibitor. What it works by keeping, I like to be very simplistic, keeping good proteins within the cell, within the nucleus. Okay, we did a previous study called Siendo. And that was led by Ignace Vergote out of Belgium. The Siendo trial was a similar trial in the maintenance setting to see if Selinexor could improve the overall survival and progression-free survival. What we found in that study, that in the entire population, what we call the intent to treat population, it was a negative trial. But in the subgroup of patients that were P53 wild type or normal expression of P53, there was a tremendous benefit of treating with Selinexor. Because that wasn't the primary objective of the study, now we're doing the follow-up study called the export trial, just in the P53 wild type patients, to see if that translates into a better outcome and perhaps FDA approval.
Amazing. And how many people are in the P53 wild type category?
So P53 wild type is probably about, I would say, 60 to 70% of endometrial cancers.
This is
a lot
great.
of them don't recur. A lot of the P53s are the early stage and they don't need systemic therapy. But we do see still about 40 to 50% of endometrial cancers that are P53 wild type.
Got it. Okay. Amazing. When you were talking about clinical trials with your patients, first of all, I guess you've already gone through a lot, but are there any other ones that we're missing where you're like, this is going to be changing the game of how we present options to certain groups?
I love the way you said that, because we're always looking for game changers. Our next class of drugs that we're looking at, or the next strategy, is to look at we've already looked at post-platinum with immunotherapy, post-platinum and post-immunotherapy with ADCs. So the next logical progression is, what do we do after ADCs? Hormonal therapy, something called CDK4/6 inhibitors or mTOR inhibitors. That's an area that I did a lot of previous work in. There's something called CDK2 inhibitors and WEE1 inhibitors that work particularly against some of these high-risk histologies. There's another agent, a CHEK1/2 inhibitor from a sponsor called Acrivon, that's looking for a specific biomarker signature. And if those patients have that signature, they're being investigated. There's another nutritional study. It's looking at what we call a PI3 kinase mutation and mTOR mutation with chemotherapy, with a low carb diet, with diet modifications. The sponsor there is FAETH, F-A-E-T-H. Really cool study, knowing that endometrial cancer is also a product of a poor appetite, a high carbohydrate appetite, to seeing if we could affect the nutritional status. A lot going on. Biomarker-driven therapies, PI3 kinase mutations that we're doing. Stephanie Gayard from Johns Hopkins is leading a trial there. Other antibody-drug conjugates in the second line that we're investigating. Okay, so I talked about first line. I should really mention the second line antibody-drug conjugates. The HER2 has an FDA approval already, trastuzumab deruxtecan. But we're looking at antibody-drug conjugates against alpha-folate receptor, against B7H4. There's a study from AstraZeneca looking at their B7H4 antibody-drug conjugate. A lot of it, the TROP2s that I already mentioned to you. So a lot of good options.
A big part of this, Dr. Slomovitz, is translating the importance of clinical trials to people who are just hearing it for the first time from you. And I know that we've covered some of the questions that people can ask, but what are other ways that you've successfully been able to describe clinical trials as an option? And are there any myths you have to commonly bust with people when they're asking about clinical trials?
Yeah, I love the way you said it, clinical trials as an option. I'm preparing a talk now that I'm giving in September to one of the national organizations. That's what it's titled, clinical option as a care option for a patient, clinical as a care option. I think there are a lot of biases against clinical trials. Patients are afraid of them. We need to help overcome those biases. Simple things. We need to educate patients that randomized phase 3 trials aren't placebo-based. Okay, they're giving the current best standard of care versus another drug. And maybe it is just better to get onto the standard of care arm because maybe that's not as good as the control arms. We need to balance out some socioeconomic imbalances. For example, we need to come up with better support services for our patients that don't have the money to take off of work, that don't have the money to park in the parking lot, or don't have the technology to do web-based quality of life assessments and things like that. There's more and more support from our industry partners to support those type of patients, to help support the caregiver that brings the patient in. These are things that are important. Really talking to our patients, explaining to them that there are no biases. There's no secrets. We're trying to get a better treatment option for our patients, and these aren't unwarranted biases. Historically, there was a lot of biases towards different populations of patients, and we need to overcome that perception.
Can you talk more about any guidance you have for fellow providers on the best way to make sure that we're not missing people based on their profiles and their backgrounds and their socioeconomic status? What are the things that you found to be very helpful in conversations with patients?
I think it's a great point. I think making sure you have a good team around you. So making sure you have nurse navigators, physician extenders, whether it be a nurse practitioner or PAs, helping the whole process, reconfirming what the doctor's talking to them about. And then face-to-face conversations, telling patients what the data are, why we're trying to do these studies, why it's important to enroll patients across diverse populations, and encouraging their participation, not just for themselves, but through, potentially helping to answer questions that'll treat populations as a whole.
Yeah, and
we're getting better. There's still biases against it, but we're getting better.
Good. No, and especially what you said when you said Black women are dying at a 2 times higher rate than peers, and due to probably different reasons. And you've got groups, I'll give a shout out to Ecana, that specifically dedicate their advocacy efforts to helping Black women feel connected and get empowered. So I really appreciate that. A very simple question, Dr. Slomovitz, is when people are thinking of clinical trial, the first time I heard it, I'm thinking, I'm going somewhere I'm not familiar with. I just don't have the information. So I start to write my own story about what it is. What does it actually mean on a human level to be part of a clinical trial? I know that there's different considerations depending on the trial, but can you just give an example of what patients are going through as they're starting a clinical trial? What does it actually look like?
The hardest, just with anything, the hardest thing is the unknown, not knowing what to expect. So there's a lot of things about clinical research that, in addition to the drug, that helps the patient get through the process. There's not only the clinical team, but the whole research team is involved with their care. I think there are some frustrations in meeting, as I said, the inclusion criteria calendar, but that's spelled out and we need to do that. So sometimes it takes a little bit more time, a little bit more forms. But again, there's the opportunity to get a treatment that they wouldn't normally get. So I think there is a great amount of unknown. But and it's unknown not for the patients, but for their family members as well. And it's sort of fostering an environment of trust, fostering an environment of transparency, of empathy, and of education in order to help overcome some of those barriers. And not just saying to the patient, "Oh, don't worry, we got you." Explain to the patients what we're doing, why we're doing it, what the need is, why are we going through extra procedures and things like that. I think that's where you're alluding to with that question.
I think people think also of like major paperwork. I'm signing my life away. How often do I have to go to the site? Do I communicate with my regular team? Is this a brand new team I'm working with? I think those are some common questions.
The doctors, there's always the healthcare provider. I'm not the only one at my site that offers the trials that I'm running. So patients stay with their doctor. There may be some extra tests, and we like to explain to the patient what we're doing and why we're doing it. And in truth, and I'm a big clinical trial advocate, there are some patients that don't belong in clinical trials. They don't want the unknown. They don't want they don't grasp the understanding that we're just, we're giving everyone the best standard of care. And you can only go so far. And it's also important, in this consenting process, and the consent is the paperwork that you were alluding to. Sometimes it can be long. They are all written in readability. They have to be written in a fifth grade understanding. And obviously a lot of our patients are better than that. But there's, the understanding through the consenting process and through the clinical trials that they don't need to do it. No one's ever forced to do it, which is exciting, which is nice.
And if people, I know we have a great site called clinicaltrials.gov. They had a refresh a little bit ago. Still not maybe the easiest or most user-friendly site to navigate. So do you have any tips for people who, we will list, by the way, the clinical trials that you mentioned, we will have the names up here and link out to them. But for people who are trying to do just their general research on clinical trials, do you have any tips on where to go?
Talking to their doctors, talking to their providers. If it's not as a busy unit, reaching out to providers and other centers. I think it's important. And then the resources you described, clinicaltrials.gov, American Cancer Society, other local advocacy and support groups. I do work with this organization, the International Gynecologic Care, IGCS, International Gynecologic Cancer Society. We initiated Endometrial Cancer Awareness Month 2 years ago. June, it's peach. Peach is the color of Endometrial Cancer Awareness Month. And there's a great worldwide advocacy outreach globally, which is something that we're working on. So I think it's a matter of digging in deep, doing some work, and getting the information you need, asking your healthcare providers, asking your healthcare extenders, and nurses and nurse practitioners, and getting the information you need to find out where the best trials are for you. The sponsors, checking whether it be Merck, AstraZeneca, a lot of these I get referred a fair number of patients from companies that patients reach out to trials and they want to see if they're eligible for their trial.
I mean, you were just talking about the patient-facing efforts, and I saw the Jump for June as one of those efforts, right? Which is really cool. And do you want to share a little bit about that? I know we've passed June, but just so people know what that's all about.
So as an aside, the CEO of IGCS, this woman, Mary Aiken, she's a good friend, and she and I are both Florida Panthers fans. So we did the jump for June. It's on the website. We were both wearing our jerseys, and we jumped, and it got recorded. After the Florida Panthers won the Stanley Cup, then we really got it out there because it looked pretty cool. We sort of predicted the victory. So yeah, jump for June. It's a way to raise awareness. Like, you can't always say, watch out for postmenopausal bleeding and abnormalities and go to a clinical trial. It's jump for June. Think about endometrial cancer. What do you need to do to learn more about it? To have, a lot of times the scariness of the diagnosis and going through the clinical trials is minimized when you're doing it with someone else, another patient. So things like that are important when we talk about public awareness.
Because we've talked about clinical trials and how there's a difference in access. When you talk about in certain places, like in the community, what is your message to both patients and other doctors who are in the community setting, so not at the big major centers, on what they can do to bring more awareness about clinical trials to where they are?
Yeah, so we want to try to get as many centers involved with research as possible. That's not always possible. Referring to their patients to colleagues who are doing the trials. Even if it's just a FYI, a for information type of referral to see if there's anything there. We're just talking to the other doctors, going to educational programs where we talk about this. We do a lot of educational work through the GOG, through other avenues, through other CME avenues. I don't say there's one area to get the information. There's a lot of different areas.
Okay, and then the last question would be for our patients and our care partners dealing with endometrial cancer, especially advanced or recurrent. What is your overall message on the landscape of treatment options and what you see on the horizon with all this development?
Yeah, it's a great summary type question. The future's bright. We're becoming better and better with our treatment options. It used to be women with endometrial cancer would get 1 or 2 lines of therapy, and then the disease was so aggressive they'd succumb from their disease. Now patients are getting 3 or 4 lines, 5 lines, and as we move forward, we'll get more and more lines of therapy with the sort of the latest and greatest therapies. I think the biggest thing the 2 biggest things that we've learned is, number 1, immunotherapy for all patients at some level of their care, and secondly, these molecular subclassifications really helped us to delineate not all endometrial cancers are the same, and different cancers require different treatments.
Amazing. All right. Thank you so much to you, Dr. Slomovitz, for your time today. I really enjoyed our conversation.
Likewise. Thank you.
All right. So, we encourage you all, from being patients to care partners, to stay informed, to ask questions, and to partner with your healthcare team to explore all available options. We'd like to thank again our sponsor, Karyopharm, for its support of this patient program. The patient story does retain full editorial control over our content. And again, while we hope that this was helpful and that you walk away feeling more empowered, please keep in mind, again, it's not meant to be a substitute for medical advice. So still consult with your own healthcare team about your decisions. And as I mentioned before, your voice is truly important to us here at The Patient Story. And so it'll just take a few minutes. If you could fill out a survey that's going to pop up after this discussion closes out, it will allow you to share with us what we could do better, what you enjoyed, and what you want more of. And so again, that's just going to come in a moment. For now, glad you could make it. Hope it was helpful, and hope to see you at a future program. For now, for The Patient Story, I'm Stephanie Trong. Take good care.